tragedy of later life is that they go from loss to loss to loss. And therefore they go from sadness to sadness to sadness.
When you begin to ask questions in the clinical setting about their sexual life, frequently people who have what appears to be a perfectly adequate and normal sexual life begin to tell it to you almost as an apology.
Also, women experience the same kinds of losses, but they don't translate it into aggression towards self the way white males do.
Welcome to another edition of Psychiatric Recorder, a continuing education service from Smith Kline French Laboratories. In this program, we examine some of the psychiatric needs of the elderly American. A distinguished panel of experts discuss such topics as sexuality in later life, depression, and paranoid projection, as well as residential care for the fastest growing segment of America's population.
We as psychiatrists usually encounter two major syndromes in the elderly. And I would like to iterate the fact that it does not matter whether the individual is organically impaired, while it does to some extent matter, or whether there is no organic impairment of the brain. The individual presents himself with certain symptoms and with behavioral patterns that, if we understand them, will be sufficient often to help the individual, because understanding means support in a certain sense.
Moderator of today's discussion is Dr. Jack Weinberg, past president of the American Psychiatric Association and director of the Illinois State Psychiatric Institute. A member of the Committee on Aging for the Group for the Advancement of Psychiatry and of the Special Committee for Mental Health and Illness of the Elderly of NIMH. Dr. Weinberg has devoted much of his professional life to the study of the elderly. A noted author and clinician, he is also professor of psychiatry at both Abraham Lincoln School of Medicine and Rush Medical College.
The two major components that one sees in later life, one, and the primary one, is that of depression in later life. And I would like to explore that with you in terms of what is the meaning of this depression, how often is it seen demographically, epidemiologically, and to what do you attribute its prevalence in our society. The second syndrome complex that one sees in later life is that of projection, paranoid ideas that come up in later life among the elderly. That too I would like to explore and to see what is it that brings forth this type of psychological response to the aging process.
Let's talk about sadness for a moment. What is it that distinguishes sadness from what we would call depression? It would appear, as we view what late life is like, probably, whatever else it is a time of loss. Loss in the sense of change.
Joining Dr. Weinberg is Dr. George J. Maddox, Director and Senior Fellow at the Center for the Study of Aging and Human Development at Duke University. Dr. Maddox, also Professor of Sociology at Duke and a member of the National Advisory Council on Aging at NIH, has conducted research into the social aspects of aging and human development.
I'm aware when we were looking over scrapbooks and pictures of myself 20 years ago, my children always laugh, and I'm not sure whether I want to laugh with them or not. I'm aware of a loss of an image of myself. Friends die. Even closer persons do. And there is an affect called sadness. When does that become depression from your point of view? I can see why there would be a lot of sadness in late life, but it's not clear to me at what point we ought to be talking about depression. That's critical in answering the question about the epidemiology of it. We've got to define the case.
Well, I thought Jack sort of defined it when he said that he is going to talk about patience. When he talks about patience, then although the affect of sadness is part of depression, the diagnosis of a depression in an older person, a patient then, is something that implies not only the affect, but certain other signs and symptoms, but most important, an interruption of function that requires treatment to ameliorate. The sadness that you're talking about, the sadness of loss of what was previously, is indeed a change.
Completing our panel is Dr. Robert J. Nathan, Professor of Psychiatry and Director of the Division of Liaison Psychiatry and Psychosomatic Medicine at Hahnemann Medical College and Hospital in Philadelphia. Dr. Nathan's clinical interest in geriatric psychiatry has led to research into the brain structure and socio-behavioral variables of the aging process.
I'm not so sure that all changes bring about sadness. I think that if you looked in your scrapbook, for example, when you were 20 and looked back to when you were 5 or 10, you might not feel sadness at that change. And I think the cultural determinants of looking when you're 50 to back when you're 20 and feeling a sense of sadness may be something there. But when the sense of sadness becomes all-pervading, when the sense of sadness reaches the point that it interferes with sleeping and eating and motility, as we do see in many of our patients, then these patients come to see us, and then we have to tease out a very difficult thing. What of these things are changes or losses that may have precipitated this depression? Frequently very real losses, loss of a loved one, and we know that for any age group, the loss of a spouse, for example, is considered a critical life event, and one that most people respond to very strongly and is a predictor in, for example, Holmes and Ray's method of viewing life event schedules, predictor of future illness, not necessarily only psychiatric illness. But then there are other losses that might be peculiar, and I don't know, I think we could explore this, might be peculiar to old age.
When epidemiologists are trying to deal with this issue, a lot hinges on the definition of the case.
Yes.
When the negative affect is being discussed, negative affect is not uncommon. One can find in sample surveys 25-30% of persons who in the previous week acknowledged significant negative affect. But that's very different from the treated cases where one has become a patient and where the more than the sadness is involved. And the estimates one sees are quite variable, but tend to be in the population generally in the range of 3 or 4%. And then estimates that for the older population it is much higher, but it's an estimate for a very interesting reason. The comments that an epidemiologist hears is that there is a high probability that psychiatrists, seeing an older person, is inclined to treat what appears to be depression as just a, quote, and I quote, a normal response. Is that a probability? Epidemiologists believe that, I think, that there is a probability that the physician, the psychiatrist, tends to underestimate significant depression in his own practice.
One of the aspects of growing old is the gradual loss, as Bob Nathan has indicated, of meaningful others. And meaningful others may not just be a spouse, and meaningful others may not just be even a loved object, but it could be someone with whom one has quarreled all of one's life and given a reason to exist. And if that person disappears, then something in the balance of that person has been upset. It is indeed true that not only are there some deficits that take place organically, physiologically, for which one can mourn to some extent, but every loss means a separation from some object that was a supportive figure in some way in the matrix of that individual's life structure and lifestyle. The tragedy of later life is that there is a gradual isolation and aloneness that takes place in the individual. And I like to make a differentiation between isolation and aloneness. Aloneness is an intensely experienced inner affect. One can be in a huge stadium at Duke University and watch a football game and feel quite alone. You can eat in a restaurant where there are loads of people sitting around you, but if you are by yourself, you may feel alone. It's because you're separated from meaningful others. George, you've heard me many a time relate my own experience with my mother, whom I mentioned at the drop of a hat. So I keep her memory alive. I used to call her every morning when I came to the office. And you're entitled, Bob, to any interpretation you might give on that.
I'd like to hear it.
I'll admit to it. Every morning she'd tell me the same thing and finish the conversation just before we hung up. I'm always alone. Now, Mother was never alone because she was in the home of my brother. She was ill, and we never left her alone. Then what did she mean when she said to me, I'm always alone? It would not do for me to say, Mother, you're not alone, because I wouldn't tell her anything new. She knew that she wasn't. But she was giving me a message. And in it, of course, as a psychiatrist is wont to do, interpreted. What she meant, I believe, was that that part of her which interfaced with me felt lonely for me before I even hung up. And that there was no one in our configuration that could replace that type of a relationship. And implicit, there was a rebuke. Why in the hell aren't you here? So that I never became angry about that. And provided with my silence the understanding that we mutually shared, that we both felt sad, alone, being apart from one another, and that it is fate or life or what have you that brings it about. There was a note of sadness in her voice when she said that. The tragedy of later life is that they go from loss to loss to loss. And therefore they go from sadness to sadness to sadness. And what you imply, George, is very much correct. That grief which accompanies a loss is something that needs to be worked through. Depression, which Bob has described, needs to be treated. And true, Bob, many a patient is brought to us or comes in because the family says he's depressed, is really going through a process of mourning for some object or meaningful other. And it is...
How common is that in your experience? It would seem to me to be an important distinction to make, because presumably a person who is grieving can very frequently be helped by more natural processes than being introduced into the medical system.
I can't give you incidence figures, George, but certainly one must clinically differentiate these two. My experience, for example, is that, and this is not just in the older population, but in all psychiatric populations, I am terribly unimpressed with the use, for example, of antidepressant medication in people who are grieving. In people who are depressed, it is a wonderful, effective tool for a psychiatrist to use. But if you get someone who lost a loved one and who is having a prolonged grieving process, you might be able to help them talk through if they don't have any source to do this. But the use of the medical tools, shock treatment or drugs, is in my experience ineffective. Now, I don't know how it is with you, and yet we see this constantly. We see 2 weeks after someone has lost something, the family physician puts them on an antidepressant because they haven't snapped up with you.
In my experience, I do and have seen individuals who came in because of supposed depression, but who really were going through a prolonged grieving reaction. I believe it is by far more common than is described. The tendency often is to immediately enter into the medical mold and to provide something that would be of help. And let me give you an experience, a case, that it is not solely the issue of the loss of a meaningful other necessarily, but some sort of an abstract idea and a notion. I saw a woman in her 70s who had had a previous depression when going through her involutional period during the menopause. And she had seen a psychoanalyst and was helped greatly, and she had some psychological know-how. And when in the age of 70-something, she suddenly became depressed. She went to see her former analyst, and he said, well, you're in the 70s, go and see Weinberg. So she came to see me, and in the process of taking a history, she told me that it has been going on for about 2 months. And I said, what's happened? And she was unable quite to describe. But then, as she went on in my eliciting a history, she indicated that her husband, who has been an invalid and a vegetable, really in a nursing home for 5 years, and for 5 years she went there every day without fail, sat near him, even though he was not conscious at all of her presence, but she was sufficiently psychologically attuned to stay with him and provide some physical contact. She would hold his hand and thereby felt that she was participating with him and providing some sort of support. Well, her friends were disturbed that for 5 years she did that, and they urged her to take a vacation. There was no knowledge of how long this man was going to go on. She decided to take a cruise. And then she told the nursing home where this man was that she was leaving for 2 months, whereupon they said to her, well, Mrs. So-and-so, you never told us what to do with husband should he die. They had no children. And so it suddenly confronted her, and she stated, well, give him to a medical school for research. Then she thought, I've never done anything about myself. What if I die? And so she made a codicil to her will that when she dies, her body would be given to... And as she was saying that, she broke down and cried. Because she said, from that point on, I look at my body and I think it isn't mine anymore. I've given it away. And what's going to be done with it? So she was not only saying goodbye to her husband, but saying goodbye in a sense to herself. And she was grieving for those 2 losses.
You make it, you said this person had psychological resources, and
Yes.
That's certainly believable what you say. I would have expected an equally probable outcome for such a person is to be terribly angry by being put into that situation. Does that happen? It seems to me the more common, and I've seen this more in middle-aged people where there's a death of a spouse, where chronic illness has been involved, where I've observed intense anger, then followed by the perception that I have killed, my anger has killed this person, and a great sense of guilt. If you had told me that story about this woman, I would have found it equally believable.
Yes, well, one of the differences in terms of making a diagnostic evaluation between grief and depression is the amount of ambivalence that the individual has had in relationship to the lost object. When there is ambivalence, when there is as well hostility and anger, as well as affection, then there's much more likely to be a depression. When there is less ambivalence, then there's more likely to be a more clear-cut grieving process. And I think psychiatrists need to make the differentiation, and that requires a good history and an openness on the part of the individual to express what the real feelings have been, because then there is guilt. Ambivalence implies it was hostile. Why didn't that man go? So I would be free.
This ambivalence and anger that you correctly point out, in my mind, once again, is what distinguishes the grieving process from the depression, and what I think accounts for an awful lot of the suicides that we see in this. 10% of the population provides about 25% of the suicides in this country.
And particularly that is true of white males in our society. It gradually goes up
That's correct.
all the way up.
Making a cultural point also that
Right.
women experience the same kinds of losses, but they don't translate it into aggression towards self the way white males do.
Because they also have difficulty in accepting themselves in a dependent position. They can't accept dependency, whereas women can, culturally determined. I would like to take a look at the other important symptom complex that we see in later life, and that is the usual and seeming paranoid projection that the elderly come in with or are brought in. I am reminded of a case where two women came to see me because their mother accused them of stealing her food from the refrigerator. They were taking it away, or taking the laundry out and bringing it back when it was all seemingly tattered or fixed, not to her liking, that they took her medication and took that away from her. And the two sisters were very upset because the reverse was actually true. They were the ones who brought the food into the home. They the ones did the laundry for mother, and because mother did not remember how to take her medication, she either took too much or too little of it, that they doled it out to her, but she felt that they were stealing it. The interesting thing was that indeed the mother, who was not sophisticated, accused them of stealing. And I said to them, let's understand what it is that your mother is saying. You told me just a while ago that when you came and told your mother, you can't handle money anymore. We are going to buy the food for you. You cannot handle laundry anymore. We are going to do it for you. You don't know how to take your medication. We're going to do it for you. What they were doing is to take function away from her. This is the role that she played all her life. That is, provide the food, take care of the household, and so on and on. And they were taking that away without providing another role for her. She was not sophisticated enough to say, you are infantilizing me. But she could say you're stealing. What she was actually saying in a symbolic sort of a sense, because patients speak to us in symbolic language, in poetry, as I like to say it. What she was saying is that you're taking function away from me. And since she could not face up to the fact that she was dysfunctional, she projected, you doing it too.
A colleague just, I heard recently, gave two illustrations that are very similar to this, and making clear what a fine line there is between, we sometimes jokingly say that a paranoid person is what every thinking person is in a threatening world. The two illustrations from clinical experience was a confrontation between a mother and daughter over ordinary kinds of things, where they parted in anger, whereupon the daughter, wanting to make up to mother for this, brought her a cake. And the next thing anyone knew, the mother was perceiving the cake as poisoned, thinking her daughter wished her ill. The other is the older person who believes that someone is stealing their mail. They aren't getting as much mail sometimes as they used to, and they look for that contact with someone that's supposed to care about them and it's not there, and they cannot believe, understandably, that people would not continue to write, so someone is stealing. Those two illustrations strike me as especially poignant because they are so everyday.
Right.
And have this outcome that is so unacceptable in a way, because after a person continues to talk so unrealistically about the environment, people tire of that. That's true certainly of non-professionals, but I suspect professionals must see that as unusual. The person continues to insist that the world is as everybody knows it isn't.
No, but these reactions, I think, are really ubiquitous. And the trap that we as psychiatrists fall into is that of giving them superficial explanations. Most psychiatrists, when dealing with something like this, would indeed see the projective mechanism involved and would indeed be able to explain it to himself and to the relative. What I don't think enough of us do is to go beyond the simple projective mechanism and see it as symbolic of the disruption of some sort of interpersonal contact. Because if you do that, then you're into a therapeutic situation, and you can indeed do this. One of my first geriatric patients, who I began seeing at 65, who's now 85, who for the last 20 years has had a grossly elaborated paranoid system. And for years and years, we spent a lot of time going over, do I believe that the FBI is tapping her phone, all sorts of things. And finally, I learned my lesson, that what I would do whenever this thing would reach the crescendo that would require calls in the middle of the night to me and things of this nature, I would begin to look for what is going on between you and your daughter. What is really upsetting you? But that's not much different, once again, than we do with our younger patients either, and I think that's the point.
In the therapeutic situation, you don't just deal with the elderly person if there's family around. You deal with the family. This is what one might say manipulation of the environment, not in a pejorative sense, but rather explain to the children, as I did to them, what it is that mother was doing. One has to deal with mothers. Projective techniques, but at least the daughters, if they understand it, do not get angry and begin to argue with her. So one has to do a double job. And like with children, absolutely, one has to deal with environmental issues. You see, we see that same type of mechanism in children. A little boy or a little girl who runs into mother who's carrying a tray of glasses, and the glasses fall and break, and the mother is angry at the child, and the child says, "You made me do it. You pushed me.
See what you made
See
me
what
do."
you made me
Yes.
do." So that there's a projection in one's inability really to assume responsibility or to indicate that I have been at fault or something is wrong with me. An immediate projection.
You know, and one of the implications of what you're saying is a point we've touched on many times before. In geriatrics, like in pediatrics, now I don't mean to bring up the imagery of being infantilized,
Right.
but the third party becomes critical here, both in terms of understanding what is going on and in terms of making some decisions about what can be done, if anything, that is helpful. The idea of geriatrics without involving the third person seems essentially an impossibility.
I think we could spend some time on that because, once again, it's always easy to make the cavalier statement that all kids of older people do, positive or negative. And actually, it's a highly complex sort of thing. This lady I was just referring to, her daughter, now herself in her 60s, can't understand and gets upset when she and her husband want to go away and want her mother to leave her apartment to come over and stay with their house and their 3 dogs. And the mother then, because of her particular psychological problem, develops all sorts of elaborate paranoid ideas about going over there, but in essence saying, really, look, I'm having trouble in my own little apartment. I don't want to go over to yours. And eventually the daughter calls me and says, how will you please make sure that my mother goes over? And I say, no, I think at this time, if you want a house sitter, I repress or suppress, you're old enough to hire one. But you're going to have to get someone to sit with your house. That goes on. But the people we get who come in and say, we have to get rid of mother, or we have to keep mother, all present different problems that we have to deal with.
We're dealing with the everyday variety that is not too difficult to understand, and maybe even not too difficult to begin managing. It would seem to me, though, there's a very different problem when one has, how should one say this, a significantly paranoid individual where there's not the capability of going on. What different kind of strategy is involved?
What we provide is a combination of psychotherapy, in this particular lady's case, when the paranoid thing reaches a point where she begins to call the police and call our two senators, and the situation gets tense, then we use some medication in small dosages. I have made it a point of principle with this lady that I do not want her hospitalized, and I will see her frequently, and I will see her daughter and her son-in-law, because I don't want her to be placed in a hospital. And at this point, after 20 years, the beautiful thing is that she will come now to the office, and we will talk about this, and I will try to figure out what is going on and interpret it. And then I will also say, let's cool it a little bit. Neither of us want this to get out of hand. And she says, yes, I understand, but, and then she goes through it a little bit more. And then I say, okay, now, I think it's this, and let's see what happens, and call me in a couple of days and tell me if you feel more comfortable. And every once in a while she'll go off and say, but you don't really believe. And I say, at this point, I don't have to believe.
That's a good therapist. And the point is that should be emphasized in terms of the therapeutic regime of these individuals. Do use some medication, to be sure, but then also frequent exposure to the individual and frequent visits of that individual. I used to make it a point that when I had 3 elderly people, and if my psychotherapeutic hour was 45 minutes, I would see these 3 people for 15 minutes each, but 3 times a week. So that I'd use 1 hour to see 3 people to establish the interpersonal relationship and the trust that they might build up, or at least the semblance of feeling that this man does understand me, even though he may not believe, but there is something that is going on that he provides. So that's an imperative, I think, in working with the elderly. Particularly is that true with some of the people who have some organic brain dysfunction, chronic brain syndrome, who don't remember. You have to be exposed to them as a therapist quite a number of times so that they'll remember you and make connections between the previous and these moments.
I think Jack is raising a point that those of us who have been trained as analysts have had to wrench ourselves away in dealing with some of the older patients from this concept of a 50-minute hour. That in particular with some of the organic brain disease people, it's probably better in my experience to see them for shorter periods of time, but on a very regular basis, than to try to do a 50-minute hour. What I try to do is keep myself flexible, that I can expand or contract. And within an academic setting, I can do this. I don't know whether in private practice you can have quite that kind of luxury, but it's sometimes necessary.
It's interesting, George, that some of the most significant contributions to geriatric psychiatry come from a group of psychoanalysts who had dared to go into this situation, but they've also felt that there's modification of the technique, great modification, much more realistically oriented, and the prohibition of not touching a patient is not true as far as the elderly is concerned. You do reach out and hold their hands. You do pat them on the back. You provide a contact which is very realistic between yourself and the patient, which is very meaningful.
This is something that is demonstrated beautifully within the general hospital setting in a psychiatric consultation with a geriatric patient, where you send your resident to interview the patient, and the resident comes back and says it's an organic brain syndrome. We can't find out anything about it. And then you take your medical students and the resident, you go to see the patient, and you put your hand on their hand, and suddenly all sorts of material comes out. And if you're feeling sadistic at the time, you say to your resident, I thought you said you couldn't get any material. And if you don't, you simply say, do you see anything that I did that you didn't do? And he says, no. I was nice to the patient. I talked to the, and did you put your hand on the patient? No, I didn't do that.
Taboo. I'd like to raise another point that often individuals are brought to the psychiatrist because they seemingly hold on to things. They begin to conserve and hoard things, food and all sorts of objects. Medication. The family can't understand what's going on. And the point is that, as I see it, and I'd like to verify it by you and you, I feel that as the individual loses more and more meaningful objects, persons, people, he begins to hold on to inanimate objects with which he or she has shared experiences.
You're describing me.
Right.
My study is filled with objects that stand for relationship.
Right. We hold on to an old theater ticket stub or to a
I hope you're going
program.
to say that that's good.
I love it.
Very good. Thank you. Thank you, Doctor.
And you spoke about, I'll send you a bill later. As far as you were talking about pictures, the elderly surround themselves with all sorts of photographs because once they take a look at the object in the absence of other meaningful object, then it is evocative of a pleasant experience or something that has happened. And they lost their friends, they lost their relatives, but there they are in the pictures, and every time they look at them, it's again flooded with feelings which are so terribly important. It makes them feel alive.
Both of you have had a lot of experience in teaching medical students. I have, in
Yes.
my own way, also over the years, had many contacts with medical students. And what we're talking about would seem to give at least some explanation of why we have such difficulty in teaching about late life. Let's assume that medicine attracts fairly independent, aggressive people. And to the extent that the selection process plays out its intended course, that's what you get. That kind of person would seem to have great difficulty, quite apart from the intellectual understanding of coming to terms with loss and dependency in late life, of doing more than acknowledging it intellectually, but in fact coming to terms with it, knowing how to respond to it, even wanting to be able to make the subtle distinctions in diagnosis. That's been my reading. You're much closer to the situation than I am. Is there a special problem in teaching the medical student to diagnose and to respond to this kind of thing?
Well, I have trouble there differentiating, as a psychiatrist, the problems that we have teaching medical students to look at the psychological aspects of life in general. And when I add to that the cultural phenomena that we had been discussing of the cultural biases toward the aged, then I have trouble differentiating this. If, we're reviewing an article just recently, Carl Menninger's classical article on polysurgery and polysurgical addiction, where he makes the flat-out statement that all physicians, psychiatrists included, are sadistic and voyeuristic, hopefully sublimated. And what that would do then in the treatment of the aged, I haven't really explored in my own mind. But certainly we find that the conviction among medical students that, you're dealing here with a population that has no resources, and that they're at endpoints, and that therefore why get involved is common. But how much of that is because of the personality of the medical student or not, I'm not sure.
Our discussion continues in just a minute. First, here's a message from SmithKline French Laboratories. The schizophrenic patient, often isolated from his family, is lost in a private world of hallucinations, delusions, and anxiety. For a wide range of such patients, STELAZINE, SK&F Company's brand of trifluoroperazine hydrochloride, provides effective relief from these and other psychotic target symptoms. From withdrawn and apathetic to anxious and overactive, convenient BID STELAZINE helps return the psychotic patient to reality. And since STELAZINE usually does not cause excessive sedation, it works with your therapy, not against it. After 18 years of extensive laboratory research and clinical experience, no other antipsychotic agent has demonstrated significantly greater overall effectiveness and significantly fewer adverse effects. These facts make STELAZINE a first choice for therapy. You should be aware that STELAZINE is contraindicated in comatose or greatly depressed states due to CNS depressants in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Also avoid using in patients hypersensitive to phenothiazines. As with all antipsychotic medications, physicians should be alert for neuromuscular reactions, including tardive dyskinesia, and other adverse effects associated with antipsychotic therapy. Dosage requirements of patients on high-dose long-term therapy should be evaluated periodically. Before prescribing STELAZINE, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. STELAZINE, a first choice for therapy, helps return the psychotic patient from his own private world. This program continues on the second side of this cassette.